Hi, so today I'll be talking about imaging the diagnosis of non-fibrotic interstitial lung disease, and this will be without an apparent cause. So this is approach to chronic dyspnea, part 14.2b. So today I'm going to talk about granulomatous ILDs and imaging in their diagnosis. We'll start with granulomatosis with polyangiitis. We'll talk about the presence of pulmonary nodules and mass lesions in GPA. We'll talk about how the radiological picture and the clinical presentation color the way we interpret the clinical presentation of the patient. We'll talk about imaging findings that result from angiocentricity. Then we'll move over to sarcoidosis, discuss the lymphadenopathy that develops in sarcoidosis. Then we'll move ahead and talk about pulmonary parenchymal findings. I'll highlight the sarcoid galaxy sign. Then we'll talk about scadding stages on chest X-ray. And then we'll finally talk about pulmonary findings that develop in sarcoidosis, but those findings that are atypical and therefore require you to rule out more common disorders that can result in such findings. In part 13.1 in this series, we talked about the case of a 56-year-old lady who had presented with joint pains, which importantly were gradual, progressively additive, asymmetric, mixed inflammatory polyarthritis with swelling around affected joints, and EMS of around 2 hours, involving the left ankle initially, followed by the left more than right wrist, followed by the left knee, and then the right, second, and third MCP joints with PIP joints. Along with that, she developed shortness of breath, which was gradual onset, persistent, progressive, exertional SOB without significant postural or diurnal variation, but was associated with chest pain for about a month. And this was a gradual onset of persistent, non-progressive, moderate to severe, sharp catching, left lower chest pain, aggravated by deep breaths and relieved by lying on the left side. So indicating left-sided pleuritic chest pain. She had been diagnosed as community-acquired pneumonia elsewhere and was treated with piperacillin and tazobactam combination at the correct dose for 7 days. There was no significant improvement in the symptomatology of the patient. On examination, there were no significant findings except for notable shortness of breath and a left more than right subscapular and infraaxillary tubular bronchial breath sound. There were no added sounds, and as I just mentioned, musculoskeletal examination confirmed the presence of synovitis. So this was the HRCT of the thorax, and in that video we used a different approach to what I'm going to discuss right now. So in part 13.1 and 13.4 we talked about chronic multifocal consolidation, and then we developed a diagnostic framework for the same. Using this, we had followed a clinical and radiological route to the diagnosis of granulomatosis with polyangiitis in the presence of clinical pretest probability, implying that granulomatosis with polyangiitis was more likely than sarcoidosis, which was much more likely than carcinomatous arthritis. We decided that one, these areas of consolidation, which just to jog your memory, are areas of airway opacification in which the pulmonary vasculature is not visible, could represent atelectasis, and we talked about why this was not atelectasis. Then we talked about how there were no clinico-radiological features to suggest malignancy, which is obviously much more common and therefore something that needs to be ruled out. And then in the third step, I developed a diagnostic framework for chronic focal or multifocal consolidation. And then we talked about such chronic multifocal or focal consolidation with specific imaging findings. And we suggested that you use a mnemonic device to remember the causes. That was CIGAR. So that represented sarcoidosis, I for IgG4 related disease, G for granulomatosis polyangiitis, A for amyloidosis, and R for reaction to IL-6, meaning Castleman's disease. So I alluded to some of the specific imaging findings of GPA in that talk, and because of that, we eventually decided that GPA was the most likely pathology. But then we found that the patient's C anchor titer was also highly elevated, corroborating with this presentation. And then the patient subsequently responded to immunosuppressive therapy with low dose steroids as per Pexivaz protocol, and then tuximab for induction and for maintenance. I plan to elaborate on the imaging findings of both GPA and sarcoidosis. This naturally is the granulomatous subset of non-fibrotic ILD, which is typically not associated with a history of exposure to exogenous toxins. So getting right into it, we're going to talk about GPA. Okay, so eGPA would look very similar on imaging to GPA, and we cannot use pulmonary imaging to differentiate GPA from eGPA. So therefore, I'm going to use GPA as a stand-in for both of these disorders. Sarcoidosis is naturally very different, as we've discussed in the previous video in this series. Sarcoidosis does not show any angiocentricity and shows significant granulomatosis, whereas GPA and eGPA both show significant angiocentricity because of the coexistent vasculitis. So starting with granulomatosis with polyangiitis, respiratory involvement in GPA is as follows. The most common respiratory involvement is actually the presence of pulmonary nodules and masses, which is present in up to 70% of cases. These are typically multiple, bilateral, and randomly distributed. Again, the randomness is because it is ANCA vasculitis. They are round to oval in shape and range in diameter from a few millimeters to 10 centimeters. Once the lesions are larger than 2 centimeters, around 1/4 of those lesions undergo secondary degeneration, resulting in cavitation. So this is a representative cross-sectional CT showing the characteristic findings of GPA in the lung parenchyma. So there are multiple pulmonary nodules randomly distributed, which I've highlighted with arrowheads, and there is a right upper lobe consolidation, which has been highlighted with a black arrow. There is also bilateral atelectasis, which naturally, as we saw, was not there in our case. In a lower section, we find that there are multiple bilateral cavitatory masses with irregular and thick walls measuring more than 2 centimeters, again highlighted with white arrows. The thickness of the walls of a cavity is, however, variable, and it is not necessarily contributory in terms of differentiating GPA from other causes of cavity formation, such as a malignancy or a infection. When we talk about the imaging plus clinical manifestations of GPA in the lungs, the epidemiology of each individual manifestation becomes quite relevant. So as you can see, at disease onset, pulmonary infiltrates are present in around 25% of patients. This increases to around 2/3 of patients over a period of time as the disease progresses. And similarly, in another 1/4, you have pulmonary nodulosis, which escalates to around 58% during the course of disease. So pulmonary infiltrate and or nodulosis are what often tip us off initially to the presence of GPA in terms of radiology. And as you can see, the clinical presentation of patients is usually that they are clinically asymptomatic unless the disease has not been picked up and the patient is allowed to gradually develop the physiological abnormalities that are typified by this kind of organ involvement. Now, as an important thing that I would like to highlight, which I did in the previous video as well, is that renal involvement in GPA at onset is only present in around 18% of cases, but over a period of time, it is present in 3/4 of cases or slightly more than 3/4 of cases. So that is something that one must be aware of, and that is why at baseline, all patients require at least a urine routine and to rule out azotemia. Basically, because of the more common presentation of patients as having incidentally detected pulmonary nodules and or infiltrates as compared to clinically symptomatic presentations, radiology of the lungs plays a crucial role in the diagnosis of GPA. Now, respiratory involvement in GPA because of the presence of vasculitis shows a prominent angiocentric nature of lesions. This is typified by this particular example in which we find a quote unquote halo around a area of consolidation. So I have shaded out the consolidation so that the halo surrounding it becomes more prominent. So this halo is basically a ground glass opacity, and these lesions are located in the right upper lobe. Similarly, in the next image, you find a nodule or a mass-like lesion with a vessel that appears to move into the lesion. So this has been termed the feeding vessel sign. I've highlighted it in red. One thing to note in this particular case is the presence of some amount of GGOs, that is ground glass opacities, just anterior to the nodule. Now there are a few things that I need to clarify. These findings can occur in malignancies. In case of lung malignancies, the feeding vessel sign is now considered to be dubious. So with the advent of reformatting and three-dimensional reconstructions, it has been shown that many of these vessels actually represent pulmonary veins, or they appear to be arteries that actually skirt around the mass lesion rather than actually going and feeding the mass lesion, as the name would suggest. However, the validity of this sign in pulmonary infarctions has not been assessed, and therefore, by extension, it remains to be seen whether this sign is still valid in the diagnosis of pulmonary or bronchial artery vasculitis related infarction, as would happen in GPA. An angiocentric nature of lesions need not always suggest GPA. There are three findings that suggest angiocentricity but are relatively uncommon in GPA and therefore require other more common diseases to be ruled out because they're more likely to present like this. So the first of these is the presence of patchy bilateral consolidations and ground glass opacities. That is, the ground glass opacities are not surrounding the consolidation, they are located at different areas. So this could represent small vessel vasculitis with local alveolar hemorrhage, but essentially any cause of chronic multifocal consolidation would result in the same presentation. And this is present in around 25 to 50% of cases of GPA. The second thing is the reverse halo sign or the atoll sign. That is the presence of ground glass opacity surrounded by consolidation. This could be the presence of organizing pneumonia-like reaction developing at the periphery of focal hemorrhage, but naturally it could also just be organizing pneumonia. There may not be any hemorrhage. So again, the reverse halo sign is actually an uncommon finding in patients with GPA. Third is the tree in bud pattern. This is because of the inflammation of the pulmonary arteriole that moves along with the terminal bronchiole as it supplies the bronchopulmonary lobule. Because of the branching nature of the vessel affected, you can get a tree in bud pattern, but this is actually a very uncommon cause of the tree in bud pattern. Any cause of central lobular nodulosis would result in a tree in bud pattern, and those are far more likely, as an infection is a far more likely cause. So again, this is quite rare in GPA. Now coming to respiratory involvement in sarcoidosis. So there are two types of respiratory involvements in sarcoidosis on imaging. One is hilar lymphadenopathy, which importantly is symmetric hilar mediastinal lymphadenopathy. And then we have pulmonary parenchymal findings, which I've shaded in blue. These lesions show a characteristic upper to mid zone predominance. This, as we'll see in our next video on hypersensitivity pneumonitis, is because the alveoli in the upper zones of the lungs, as compared to those in the lower zones of the lungs, tend to wash out at a slower rate, because during each respiratory cycle they distend less and therefore their volume changes less. If this doesn't make sense to you, you can go ahead and look at the first video in this series where I have talked about the same. Now, the hilar nodes are almost always involved in cases of sarcoidosis, but there are two principles that are always important to keep in mind when considering whether or not sarcoidosis may be responsible for hilar lymphadenopathy. The first is that limited hilar lymphadenopathy in isolation is very unlikely to be sarcoidosis. What that means is that isolated unilateral hilar lymphadenopathy is a very uncommon presentation in sarcoidosis, and it is only found in 1 to 3% cases and likely represents either an infection or a malignancy. Similarly, an isolated anterior or posterior mediastinal lymphadenopathy is again rare. The other thing is that sometimes when we're very lucky, granulomata may be visible within a lymph node. Even on imaging, a name sign that is used to describe this finding is what we call the cluster of black pearl sign, in which you find 1 to 2 millimeter nodules distributed uniformly within a otherwise homogeneously enhancing lymph node. Now coming to the parenchymal findings in sarcoidosis, the lesions that are typically seen are one, nodules, which have a characteristic perilymphatic distribution. This is highly specific, and actually the only other reasonable cause of a perilymphatic nodulosis is a lymphangiatic carcinomatosis. However, rarely even in sarcoidosis you can get a random pattern, which more colloquially is called miliary sarcoidosis, in which case naturally tuberculosis would have to be ruled out, or even a endemic mycosis would have to be ruled out. Similarly, ground glass opacities, more so than consolidations, may be seen in sarcoidosis, and this is often termed alveolar sarcoidosis. Finally, fibrosis can be present in 20 to 25% of cases, and that shows a upper lobe predominance. Now, coming to the sarcoid galaxy sign, this is a perilymphatic nodular interstitial pattern surrounding a region of central consolidation. It's not just presence of small nodules around a big conglomerated nodule, as you might see in tuberculosis, for example. The nodules have to be in a perilymphatic distribution. When you talk about pulmonary involvement in sarcoidosis, scadding stages need to be talked about, and these are described on chest imaging, basically chest radiographs. So stage 1 is basically a hilar lymphadenopathy that is apparent on a chest X-ray without any pulmonary parenchymal involvement. So in this particular chest X-ray, we find a left paratracheal stripe, which I have highlighted in blue, and we find that it is thicker than normal, indicating that there is likely left paratracheal lymphadenopathy. Now in the second stage, you get hilar lymphadenopathy and parenchymal infiltrates. Again, in this case, we have reticular interstitial opacities in both lungs with mediastinal lymphadenopathy. In stage 3, we get only parenchymal involvement, and this is actually relatively uncommon. Here we find bilateral quote-unquote miliary pulmonary infiltrates without any apparent mediastinal lymphadenopathy. Now this would naturally much more likely represent tuberculosis and would require you to rule out tuberculosis before thinking about sarcoidosis, especially in places like India. Now in stage 4 we have fibrosis, and what we find is that there is parenchymal scarring with some emphysematous changes. Now the naming may suggest that there is a temporal progression from stage 1 to stage 2 to stage 3 to stage 4, but this is not necessarily the case, and patients can move from any of the other stages to stage 4, and as we've discussed, fibrosis only develops in around 1/4 of cases. In other cases, the lesions just resolve on their own. The upper lobe predominance, however, persists even till fibrosis has taken hold. Now there are a few findings that can technically occur in sarcoidosis but are atypical for sarcoidosis and therefore require exclusion of more common differential diagnosis, very similar to what we did with GPA. These include pleural effusions. In sarcoidosis, you can get both transudative and exudative effusions, and these are usually small to moderate and always transient. They do not persist. The differential diagnosis of this, especially if it is exudative, is extrapulmonary tuberculosis, which is far more common in India, and therefore that would be the first thing we consider. The overall prevalence of pleural effusion in sarcoidosis is less than 10%, and therefore one must be very careful while attributing a pleural effusion to sarcoidosis. Similarly, any mass lesions in sarcoidosis are uncommon. They form in sarcoidosis because of granuloma formation, but secondary tissue necrosis has been described in literature, but is highly unusual for sarcoidosis and would imply a coexistent vascular injury or coexistent infection. Any cause of necrotizing pneumonia, particularly pulmonary tuberculosis, is far more common than sarcoidosis in India. This is a rare finding in sarcoidosis, therefore one must always exercise caution. Finally, we have mosaic attenuation. Now, in sarcoidosis, we actually get pulmonary mosaic attenuation due to hypoperfusion more than air trapping. Again, in sarcoidosis, this just depends on the scadding stage, because as you move more into stage 4, that is the degree of fibrosis worsens, the prevalence of pulmonary hypertension also increases, with pulmonary hypertension actually being very rare in isolated pulmonary involvement, or stage 2 or stage 3 rather, and being present up to 70% of cases once the FVC is less than 70%. So the presence of any such findings, particularly in India, should prompt investigation for mycobacterial infections. And as sarcoidosis is an autoimmune disease where you have excessive Th1 polarization against random antigens, there's nothing to suggest that that antigen could not be a mycobacterial antigen, and that is something that we must therefore always rule out. TB and sarcoidosis can and often do coexist in the same patient in places with high base rates of tuberculosis, as in India. So in this video on the usage of imaging in the diagnosis of non-fibrotic ILDs without apparent cause, with emphasis on granulomatous ILD, I have talked about GPA. We've talked about the pulmonary nodules and mass lesions that are also prevalent in GPA. We've talked about the prevalence of radiological versus clinical presentations epidemiologically in GPA. We've discussed the imaging findings that result from the pathological angiocentricity that is seen in GPA as there is vasculitis. Then we moved over to sarcoidosis. We discussed hilar lymphadenopathy in sarcoidosis, pulmonary parenchymal findings in sarcoidosis, and specifically the sarcoid galaxy sign. I described the scadding stages in sarcoidosis, and finally we ended by describing some findings that may develop in sarcoidosis, but however are in any case very atypical and therefore warrant exclusion of more common differentials, such as in particular tuberculosis and in some cases malignancies. So thank you, and I'll see you in the next video where we'll discuss the differential diagnosis of angiocentric mass lesions in the lung.